Hey, everybody, welcome back to another episode of CCTPD. For those keeping track, that's Collaborative Corner, the podcast. Oh, I spelled that wrong. Hold on. CCTPC. Yeah, I'm working on it. It's a work in progress. I'm a visual medium. That's what a lot of people say. But hopefully we'll see why we go there. This is our second episode on our podcast. And before we bring our guest in, I did want to comment on a couple things that I think we might want to collaborate on as optometrists. I'm always looking at clinical trials as somebody who's been an investigator and actively investigating right now for clinical trials, about to start 2 more. I always love to look to see what companies are bringing to the market. For example, there's going to be a new indication for Tarsus for their medication for lotilaner. Now, many of you probably are utilizing lotilaner for Demodex blepharitis, but they recently just came out with 2 studies. It's the URSA and the RIA study. And essentially what they were doing was taking patients that had Demodex blepharitis, and they were also looking at meibomian gland dysfunction. So that combination of both meibomian gland dysfunction as well as patients who are associated with Demodex blepharitis. So the criteria basically was to have some glands that weren't yielding as well. They had to have some eyelid erythema. Tear breakup time had to be a little bit lower, as well as intact partial to full medium glands, about 1/3. So if you think about it, you see those collarettes at the base of the lash, and essentially you start treating them for Demodex. You also want to know, hey, I wonder if I'm also managing the meibomian gland dysfunction at the same time. And so what's interesting is that this study is that they used the vehicle in their one study arm, which was the RIA study, and then the URSA study. They basically evaluated the patients with meibomian glands, and the data came out, and it basically shows, concurrently they are managing the Demodex in the exact same way they would have with just lotilaner without meibomian gland dysfunction. But it said it demonstrated statistically significant improvement in the measures of the collarette reduction, meibomian gland function. But then also they looked at some patient-reported outcomes. And for those of you keeping track, whenever you see VAS, visual analog score, that essentially is a line that is 100 millimeters, and it says, I have a problem 0% of the time, or I have a problem all the time, and you just put a line in there. So that VAS is always like a patient-reported symptom, and they found that their patient-reported outcomes at 6 weeks were, compared to baseline, were significantly and clinically better. So kind of exciting. So they're going to probably get an indication within there saying that it also manages meibomian gland dysfunction concomitantly in patients that have Demodex blepharitis. Another thing real quick that I think is kind of interesting that I think you should be on the lookout for is Sight Sciences just finished their Sahara study. And if you don't know what the Sahara study is, I'll just tell you real quickly. It was a comparison of a 6-month treatment of cyclosporin 0.5%, otherwise known as Restasis, versus a single treatment of the tear care treatment for meibomian gland dysfunction as well. And the whole point of the Sahara study, a 2-year study, long study, just concluded, was to demonstrate whether or not a single treatment of the tear care procedure was better, equivalent, or maybe inferior to utilizing Restasis for 6 months. And in their study, they found that it was superior almost across the board. Tear breakup time, absolutely, but it was non-inferior for Schirmer's, non-inferior for ocular surface disease index, the symptoms, non-inferior for staining, meaning that it performed as well, if not better, than cyclosporin with one treatment. Now, you may be thinking to yourself, why does this matter? I mean, why do I care? Well, I'll tell you why you care. Because they're going to insurers and saying, look, instead of spending all that dough, all that money to pay for cyclosporin that patients are barely using, and there's some studies that show that patients stop using cyclosporin within 4 months, we can do an in-office procedure that could be covered by insurance for patients, upwards of the tune of, let's say, $1,300. So, you'd be able to utilize that in your practice, as well as provide it for many, many different patients. So the Sahara study is really kind of a litmus test to see if we can't get this approved for meibomian gland dysfunction for in-office procedures, because let's be honest, adherence is really the key here. And if you can do something in the office for adherence, then it's way better than having patients go home and try to do it. So a couple things kind of on the horizon, kind of cool and kind of neat. And hopefully, when we come to this podcast every month, I'll try to bring something different like I am right now. I think that's a good segue into our guest when we say different. I once was introduced to a girlfriend as he's different. I don't know if that's a compliment or not. Yeah, Steve. We have Steve Ferrucci from the Sepulveda VA. Steve, are you the director of the Sepulveda VA, or what are you over there?
I'm the chief of optometric services. How's that
Chief
sound?
of Optometric Services. For those of you who don't know, Steve and I met in optometry school on the very first day of optometry school.
True
We
story.
just celebrated we're going on our 31st, yeah, 31st anniversary or whatever union of optometry school. We met the very first day. And he's annoyed me ever since. I'm just wanted to share that. Yeah.
But wait, if we graduated 31 years ago, no?
Yeah.
Or,
Yeah.
so that means we've known each other for 35 years,
Oh, for crying out loud. You're right. I didn't even think about
right?
that.
Just
Ay, ay,
simple
ay.
math, my
Yeah, I
friend.
knew
Simple
you when we
math.
both had hair. What's funny is
Yes.
that how often do people come up and go, "Oh my God, I saw your lecture and you're terrible," and I'm like, "No, that was Ferrucci," and yeah, so
Yeah. Someone had a full 5-minute conversation in an elevator, convinced that I was you.
yeah, and then you started talking and she realized you weren't. You're way too smart. You're way too
Yeah,
smart. You can't be Mark.
you make
So
sense.
Steve, so Steve,
Yes.
interestingly enough, we talk about different, but Steve, you primary. I have to say that we always tease about the fact that it's like I spend most of my time in the front of the eye, and you spend your time on the shiny red in the back of the eye. Well, speaking of the past, I
Yes.
think we've seen a lot of excitement around geographic atrophy. And in the last few years, we've gotten some medication. So maybe you can kind of give us a little, how are they doing? Where are we at with some of the GA meds?
Yeah, sure. Well, there's two of them, Syfovre made by Apellis and Izervay made by Astellas. They've been out for almost 2 years. The Syfovre pegcetacoplan came out just about 2 years ago. It's February of 2023, so about 2 years ago. Then Izervay or ACP, see, they did abbreviate the ACP, came out about a year and a half ago, August of 2023. And, they're being utilized. They're probably being underutilized. I don't think that there's been as much of an uptick as I thought there would be. But they have been shown to decrease lesion growth, geographic lesion growth by about 25 to 30% or something like that. So it doesn't reverse it, doesn't halt it, and it's stop in right away. The idea is you were saying, what you want to do is really make sure these patients, die of something else with usable vision in a way, right? So what we're doing is we're just giving them longer time with usable vision. That's essentially what we're doing with these medications. I use them quite a bit. I refer patients for them and that sort of stuff. So it's out there. It is being used, perhaps underused.
So you say it's being underused, and this is always I feel like this has always been a challenge for us as optometrists. Is that I mean, literally anything and everything comes through our practice, but the focus tends to be on our ophthalmology colleagues. They're bringing out a new drug. Let's go to ophthalmologist. Oh, we're thinking about doing some sort of, treatment or diagnosis. Let's go to the ophthalmologist. When it's the optometrists it's the proverbial gatekeepers. But more importantly though, you know, with retina, I mean, we're the ones who are going to be managing these GA patients. We're the ones who are going to be seeing these patients. So who's is it us? Are we not referring these patients in a timely manner, or is it that the ophthalmologists are holding back from utilizing the treatment?
So first of all, I would say that both these companies really did a good job from day one, realizing that primary care optometry and to a lesser degree, primary care ophthalmology are the ones that have these GA patients. Because since there was no treatment, they were in our practices. So I think they've done a good job, in my mind, coming forward and trying to educate optometrists what to look for and when they should refer. So I think they've done a good job. Whether or not people are listening, I'm not sure. But one of the issues is that it slows down the growth. It doesn't miraculously fix stuff, right? So, and there are some side effects with the medications as well, like with virtually any medication. They are intravitreal injections, so there's that as well. So that there are some concerns, and some retinal specialists are a little bit slower adapters than others. So there's roadblocks, but I think we're getting there.
It's interesting because as I'm hearing you talk, there's so many, corollaries between what we do. Cross-linking for, keratoconus or pellucid, it doesn't improve the quality of your patient's vision. It just tries to retard the progression of that cone. And so, there's a lot of hurdles to go there, but that preventative, proactive treatment is something that as optometrists, I totally agree with you. We don't do enough of either. We're very, which is better and giving the better. We're very find a symptom, give a treatment. We don't do a good job and I know we always use that dental model, going to dentists, where it's like, let's do this to prevent this from happening. What things do you think ODs should still be looking for? And I'm excited to hear, I heard this statistic recently that about 70% of optometrists have a form of OCT. Now, do they know how to read it? Do they know how to use it? What do you think that
Right.
number's wrong? Wait, I saw a
I don't know.
little.
I've heard
Yeah,
that number
yeah.
too. I'm not sure. It's really hard to figure these numbers out, right? Because how do they figure this out? So I have no idea.
They call up the offices and go, "Do you have an OCT? Do you have a refrigerator running? Oh, you better
Right.
catch it." Thank you. I'm here all
Dad joke.
day. No, so
Yeah.
Steve, like what things should you be looking for early on besides just visually seeing atrophy? And the one thing that I always it took, and I know we're spending a lot of time talking about this because I do want to hear about some new stuff. But as you just said, it's like we have treatments, and I mean, I'm not gonna lie, Henry Winkler is doing Syfovre commercials now. I got excited. I saw the fawns, but I also got excited the fact that I'm old because I remember when he was cool, and now he's this older guy, with a possible GA. So what kind of things should we look for, and how can we get these patients in a more timely manner to kind of force that retina specialist to consider it?
Yeah. So what I'm doing now, if I see a patient with GA the first time, a lot of times first time I'm not going to make a decision what I'm going to do, right? If I see the patient first time with GA, I'm probably going to have the patient come back, do serial OCTs over some time, and see is there in fact progression. When I do serial OCTs, I'm going to do the B scan, the cross section. I'm also going to look at the en face image because the en face image, I think, is really valuable to look for subtle signs
Are you
of
speaking English,
progression.
by the way, on FOSS?
Yes. So when you do an OCT, right, generally we think of the cross section. We can look, say, is there edema? Is there no edema? That sort of stuff, right? So that's what we think about. But when you look at the en face image, that's the one that kind of is like the image that you're looking down into the retina. So it's a one dimensional thing, scan of the retina. So it's almost like a black and white picture, if you will. And
Exactly.
that's a nice way to look because you can actually see progression growth over time of these lesions. Also, it's a really nice way to track how close it is to the macula. Some of the newer OCTs have software that will track that for you. I have a somewhat older OCT that does not have that capabilities, so I can measure them manually, which it's just a little more cumbersome, but it can be done. So if you really want to see how much is it progressing, but use the eye test. And now if I have a patient come in with geographic atrophy that I've seen before, now I'm looking through their last couple scans to see, oh, is this stable or is this not stable? And if I see one's progressing, those are the ones that I start to think about. This might be a good person for a candidate for this new treatment.
So the one thing that I did not hear you say, and I think it's important, is you didn't say their vision.
Yeah,
You're
vision,
strictly
yeah.
looking at scans, right?
Correct. Vision is somewhat irrelevant because if you think about it with geographic atrophy, generally speaking, it starts extrafoveal and works its way towards the fovea, right? That's generally how it starts. It generally doesn't start under the fovea. It can, but generally does not. So it'll march its way towards the fovea. You're really not going to get vision loss until it hits that fovea. And that's what you want to prevent. Once it hits the fovea, it's sort of a little bit too late. You really want to get it before it gets to the fovea. So a lot of these patients, they won't really have symptoms of decreased vision. They might say, oh, I lose my place when I read, or I have some little missing areas in my vision or something like that. But they usually don't say I have decreased visual acuity. So I don't use visual acuity that much at all. So that's a
Awesome.
true statement.
Good.
Yeah.
Yeah. We're going to have to get to the bottom of that percentage of doctors that have OCT. And too bad there's not like a red, green, yellow for GA, because then I think every OD would be like, oh, well, you're in the yellow, you're in the red. And it's just,
Yeah.
yeah,
Oh,
anyways.
that's interesting.
Yeah,
I
no,
might
it's
be
not
onto
interesting.
something
It's
there.
never going to happen. Please. So, Steve, let's switch gears a little bit. Let's put some blood. Let's put some blood in the macula, or maybe around the macula. Are there we've been dealing. We've had. I almost kind of feel like VEGFs have just been they've been there forever.
The anti-VEGFs have been around for just about 20 years, I think.
Has it really been 20
Yeah, I think
years?
so. I think so.
Oy
I think
vey.
maybe not 20, definitely 15 though.
Yeah,
So
yeah.
I
No,
think,
time is a flat circle. It really
yeah, no,
is.
I think it was. I think that Macugen came out in 2004
All right,
or
we'll get.
2004,
I have a
2005. So
I have a whole research group in the
yeah, yeah,
background.
yeah,
They'll
yeah,
get
yeah,
on that,
yeah.
and
Good,
we'll
good.
find out.
Yeah, good. Yeah, this is a very sophisticated podcast.
Yeah. Hey Siri, when did go? I'm sorry. Was that out
No,
loud?
but I'm pretty sure it's 20 years. But so we have a couple new ones now. And, really the new ones haven't really been shown to be more efficacious, but they last longer. So the new thing is sort of less injections. Anything you can inject patients less, so they don't have to come back every month or every 2 months, but can come back every 3 or 4 months for injection. That's considered a positive. So there's a couple. They now have ILEA, and ILEA has been around for a while, but now they have ILEA HD, which stands for high dose. So in the past, you would inject 2 milligrams. Now they did studies looking at 8 milligrams injections. And essentially what they found was that it works as well, but you can inject patients much less frequently. So longer half-life, inject them less frequently, which is nice. There's another medication that was FDA approved a couple of years ago called faricimab by Genentech. And it's what they call a biphasic molecule, in that it has two sort of arms to it. And one arm is an anti-VEGF, and one arm is an anti-angiopoietin A. And what they found was by using these two things together, again, it doesn't necessarily work better, but you get a longer duration. So a lot of the retinal specialists really like these agents because you just don't have to inject the patient quite so
So
frequently.
what is the average injection time? Because I remember, it used to be like what, monthly? I mean,
Yeah, I
weekly.
mean, when it
What was it?
started out, you did monthly. What most retinal specialists do now is they'll do a loading dose, one injection a month for 3 months, and then follow that patient, individually and decide when they need the next injection. Because every patient responds a little bit differently. Every patient have a little bit different disease. So now they call it kind of extend and treat. So the goal is to treat the patients when they're needed, but don't just treat them for the sake of treating them, sort of. So along those lines, they now have a new OCT, a home OCT that has actually been FDA approved, that might really help determine when a patient needs the next injection. And it's made by Notal Vision, that also makes a 4C home, which is for dry AMD. But essentially what it does, the patient can actually, you can prescribe this home OCT for this patient. And the patient does the OCT, the results get sent into a reading center, and essentially it's looking for fluid. It's looking for any fluid in the retina. And the retinal specialist who prescribes this can actually set parameters as to when to be notified, how much fluid for Mrs. Jones is too much. And when she gets that fluid, it will automatically signal the patient and the ophthalmologist that, hey, Mrs. Jones has some leakage. She should come in for the next injection.
Really?
Yeah. So it's
So
pretty cool.
is
So
that covered by like Medicare or how?
so
I
that's
mean,
the
is
so
it?
this just got FDA approved like late last year. So I think they're still working through, how much is going to cost, is it going to be covered, exactly how it's going to be done. I don't think has 100% been worked out yet, but they have it FDA approved and the technology's there.
It
So it's
uses
pretty cool.
AI. I mean,
Yeah. Yeah.
that wow. Yeah, I mean, because I almost kind of feel like that's the holy grail a little bit.
Yeah.
Doing
Sure.
something that's either handheld, portable, or maybe even something that's like sustained release that could just somehow they could put a tablet back there that just releases some of the medication. That's actually pretty cool. I mean, there's another one too, like a camera that for diabetic retinopathy that uses, does that use AI? What is that one?
Yeah, there's a relatively new. It came out probably about 6 months ago, maybe 8. Sometimes you lose track of things, but it's called the Aurora AI, and AIAEYE. Get it? AI.
Oh,
It's
I
kind of a
got
play
it.
on words.
I
Yeah,
got
right.
it. Yeah.
It's made by this company called Optomed, and it's a handheld camera that actually uses AI to assess the level of DR. So you can take a picture and instantly in real time you take a picture of someone's retina, you hit a little button and it sends it to wherever the heck it sends it, right?
The
It
cloud.
uses
Goes to the
the cloud.
cloud.
Yeah. Which I just still don't get,
I
but
know.
that's
Is
okay.
whenever they say something's in the cloud, I look up. I don't
Yeah,
know. I don't
same.
know why.
Yeah,
I look up.
same. But it sends it to the cloud and then it will come back and actually it'll say referable diabetic retinopathy detected or no referable diabetic retinopathy detected. And they've been shown to be about 90% specific and sensitive. 99% patients are able to get a usable image. So it's pretty impressive. I don't know if it's going to have a huge impact in optometry or ophthalmology because, we're looking at the images. We sort of know if they have retinopathy. But it might in an endocrinologist's office or a primary care doctor's office, certainly have some usability there.
Well, I think to your point though, Steve, is that I think AI is not something we have to, push away from. We just established, Steve, that we've been practicing for 3 decades. And one of the things that I know that I'm proud of, and I know that you are too, is that we embrace new technologies, we embrace new treatments. We're not, oh, well, the one we used to do it, and AI is one of those things. I mean, I'm excited about AI because I suck at writing in charts. So if I could just do like an AI transcription, which is readily available. I've seen some of your lectures. I mean, Chat GPT has really helped you a lot. In fact, for some of you who don't know, Steve's really not even here. This is actually an avatar. But along those same lines, Steve, are you familiar with oculomics?
Oculomics. I don't, boy, that's a tough word. Oculomics. I don't think I
Oculomics.
am.
Okay, so
What are they up to?
this is the science. No, it's not they. This is it's the science of quantifying ocular biomarkers related to systemic disease by applying AI to retinal images. So imagine, I mean, this is companies like Microsoft and Apple and other places. It's a retinal imaging technology that provides a unique opportunity for non-invasive in vivo assessment of systemic conditions. So essentially like neurodegenerative diseases, cardiovascular, inflammatory, metabolic, renal diseases, just by looking at the retina on this picture. I mean, so the areas are going to be targeted or pre-screening or screening identification, maybe even, monitoring or prognosticating what somebody's disease state would be. So I just want to ask you your opinion. Do you think that that's something optometry would embrace? The ability to look in somebody's eye and say, using oculomics, it looks like you might have early signs of Alzheimer's or cardiovascular disease. So I'm going to refer you, what's your thought of that?
I don't know if we will, but I would think that we should, because that's pretty, valuable information. And if it's information that you can get simply with an OCT, we already have OCT. Someone once told me 70% of optometrists have OCT.
I
Someone
heard
even
that
told
number
me that.
too. And I
Yeah.
think the person who said that was really, really, really intelligent.
Yeah. So, I mean, why not do that, right? But when you start to think about this AI, I mean, it just has so many different capabilities. I mean, I even think like for geographic atrophy, we were talking about that. There's other biomarkers that we look at for geographic atrophy. Hyperreflective foci, they're
Yeah,
called.
that's what I was thinking about.
There's these little hyperreflective foci, the little dots in the retina, and they found that they're predictive for patients who are going to get geographic atrophy. You also have reticular drusen, and there's other things as well. So why couldn't you use some sort of an AI algorithm? You do an OCT scan on a patient, use an AI algorithm, and it evaluates all these things and gives you this patient has X% chance of getting geographic atrophy in the next so many years, right?
Yeah.
So to me, this seems like something that someone could figure out. So why we wouldn't embrace stuff like that? I don't know why we wouldn't. No, I think we should if we
Yeah,
really
I would
want to.
definitely.
I mean, you can not like AI, but it's here, and you have to deal with it. You can't ignore it. We have to figure out ways to put it into our practice and figure out how to use it.
Are you familiar with the Valeda therapeutic device?
Uh, Not horribly, but somewhat, and that's kind of interesting too. And this is another thing. I don't know 100% what type of mark it's going to make or how it's going to be utilized, but essentially, it uses photobiomodulation. So it uses various wavelengths of light, supposedly to strengthen the mitochondrial function in the retina for patients specifically with AMD.
Interesting.
And it comes in like a box. It's almost like a little,
Like an auto
not quite as
refractor almost or something where
yeah.
you
That's
just
a
stick
good
your
yeah.
face in it.
Exactly,
Yeah.
exactly. And these patients they look into it with AMD. They look into it for a certain period of time, and they can do this. And they feel in studies that they've shown that it has actually done a couple things. They've actually been able to patients that used it over a 2-year period actually had, on average, at least one line gain of acuity. And patients also had less bad things happen, less geographic atrophy, less conversion to wet macular
Interesting.
degeneration.
I
I always say
wonder.
to me, it's kind of sounds like you're talking about cross linking. It almost sounds like cross linking of the retina in a way, you know?
Interesting. Yeah.
Yeah.
No pupil dilation.
Yeah.
Just. I mean, how many sessions are
So,
delivered?
yeah. So what they say they want to do 9 treatment sessions over a 3 to 4 week period, and then the patient then they go for like 4 months without a treatment. Then they come back for another treatment. So they do
Interesting.
2 to 3 cycles over the course of the year. And this has actually been approved for quite some time in Europe. It's actually been done in Europe for quite some time. So they recently got it FDA approved in November of 2024 for use in the United States. Exactly how it's going to be used, who's going to use it, remains to be seen. My understanding is that it's going to be at least for the first year till they get all insurance stuff fixed and whatnot. It's going to be patient pay for the first year until they can figure out if they get approval for insurance coverage. So I don't really know how it's going to work out or who's going to work it out, but it's exciting. I mean, it's definitely something novel, something new. That maybe some optometrists can add to their practice for another revenue source.
So you think that ODs will be able to do this? I
I
mean,
don't see why not.
yeah.
It's only light. I don't see why not.
We're running up on our time here, so I want you to kind of just quickly give me some stuff, especially because we're kind of focusing on mac degen. We could talk about diabetic retinopathy, but let's be honest. You see a little microhemorrhage, maybe you see a little IRMA. You follow it. Yeah, right. Am I wrong? Am I wrong about that?
Whatever you say, Mark.
H1C, Beachfront Avenue. You just find out what's going on with these patients. So let's keep it to the Mac Gen. Anything coming up on the pipeline? Anything we should get super excited about? What do you think?
So there's a couple things, and like it's really who knows if they're ever going to come to fruition. But there's another company that's coming out with another geographic atrophy medication. Hopefully, I mean they're still in phase
Whoa, whoa, whoa,
two
whoa, whoa, whoa!
trials,
Stop for a second.
phase three
Hopefully,
rather.
hopefully, what? Meaning that you want to? You think it's gonna be better than the other two?
Oh, I don't know. Who knows?
Does
But
this
it's
work
always
on the
nice.
complement system also,
Yeah,
or
yeah.
what?
So this actually works at the complement system C1. The other agents work on either C3 or C5. And if you talk to the company, there's reasons that they targeted the C1. They think that they can prevent damage further upstream so that they don't get as much damage. It's made by this company, Annexon. So they're in phase 3 trials. It'll probably be at least a year till we know. Um, Other things, it's kind of interesting. There's a couple of there's a new thing that is made by this company called Nacuity Pharmaceuticals. It's a new tablet actually that they're looking at for patients with retinitis pigmentosa. So it's actually an oral treatment for retinitis pigmentosa that has something to do with the oxidative stress, and it targets oxidative stress. And they feel by reducing the oxidative stress they can hopefully prevent the progression, or at least slow down the progression of retinitis pigmentosa. It was just given the FDA fast track status
Oh,
within
cool.
the last month or so. So that's something that's kind of exciting because we don't have anything for those patients. Another thing I think is interesting, there's this company called Neurotech Pharmaceuticals, and they're coming out with a treatment for macular telangiectasia type 2, which, it doesn't affect a lot of people, but it's a disease of the macula where you kind of get these right angle venules that lead to leaking in the macula, and then patients can have subsequent loss of vision. So they have this new cell therapy where it's actually like a little implant that's actually inserted into the eye that gives this medication over a certain period of time, which is kind of interesting. And I think, a lot of the newer things are looking at, rather than doing injections of medication, can we do some sort of sustained release? Whether it's a tablet or something inserted into the eye or something like that. So I think that's probably going to be some things we're going to be seeing over the next couple of years. The interesting thing about neuropharmaceuticals is that, and it's only interesting to me, by the way,
Yeah,
I'm the only
it will.
person that cares about this,
We'll see. Yeah,
but
go
their
on.
headquarters is in
Yes.
Cumberland, Rhode Island.
No. For listeners out there, I want you to know, for as long as I have known Steve, if you ask him what Cumberland, Rhode Island is, his response always is, "Where's Cumberland, Steve?"
It's in Rhode Island. It's in the
It's right
very
out. It's right
northern part
outside.
of Rhode
It's
Island.
right outside Providence. Right outside Providence.
Everything in Rhode Island is right outside Providence. But anyway,
Steve is
I grew up
from
in
Cumberland.
yeah, I know.
Yeah.
I grew up in Cumberland, Rhode Island. It's a tiny little town. I think it maybe like 20,000 or something like that. I don't really know. And their national headquarters is in Cumberland, Rhode Island. Just poof.
That is awesome.
Yeah, so it's interesting. I mean, stuff like that is kind of cool. So, but I think that's going to be the next big thing. Rather than injections, try to look at a
Yeah,
sustained release
you're
molecule.
100% right. And I think, as we wrap up here, it's like, I think for us as ODs, we have to, it's getting patients to be adherent to the treatments that we're sending them home with is just, it's so hard. So to me, looking for treatments and looking for things that we can do in the office, so sustained release tablets, or just having something inserted, or even better yet, a treatment you can do at your office to help continue with the longevity of your treatment, or for just to kind of slow down the progression of whatever disease state you're trying to do. I think that the critical thing for me is getting patients to believe what you're telling them, but also just to trust you. And I think the best way you can build trust with patients is doing what you're doing right now, Steve, is just saying, look, this is what we got now. We've got some stuff coming up. Or, in my personal opinion, this is what I've seen. And I really feel that, it's giving your patients the pros, the cons, what's in it for them. Yeah, it's pretty exciting. Retina's crazy, bro. Crazy stuff. Crazy stuff. Anything else you want to throw at us real quick before we let our listeners get back to their life? Or I'm always curious what people are doing. When you're listen to a podcast, because for me, oftentimes I'll listen on an airplane, and then I'll wake up and realize that it's over.
I listen at the gym. Sometimes I'll listen to a podcast at the gym, not yours,
Yeah,
like a real podcast, like a
yeah,
good podcast. I
yeah.
listen to at the gym.
That's really
Yeah,
sweet.
yeah, you're welcome.
Yeah,
Yeah,
yeah. So
so
very
that's what I
cool.
like. That's when I like to listen to them.
All right. Well, you know what? On that note, let's wrap this up here. Steve, always a pleasure. I will
Thank you, my
be
friend.
seeing you soon. And for those listening, thanks for joining us. And don't forget to like us. Ask your friends to subscribe to the Mod Podcast here. All right, everybody. Thanks for listening. And get out there. Thanks, Steve.
Thanks, Mark.